So good afternoon, everyone, again. I would now like to introduce Anne Livesey and Evelien Gevers. Anne is a consultant paediatrician who specialises in child development. She's had a particular interest in Prader-Willi syndrome for many years and has worked more closely with children and young people with PWS, their families, carers and other professionals through a multidisciplinary PWS clinic for 16 years. She's also a trustee of PWSA UK. Evelien gained her medical degree at the University of Leiden in the Netherlands in 1991. I'm sorry, I haven't got my reading glasses on. She was awarded a PhD on the effect of pubertal hormones on growth and growth hormone secretion. She was trained in paediatric endocrinology at Erasmus Medical Centre, Sophia's Children's Hospital in Rotterdam, the Netherlands, and University College London and Great Ormond Street Hospital. Simultaneously, she worked at MRC, National Institute for Medical Research in London, to do research in growth hormone, growth and pituitary disease. Evelien is interested in developing new treatments for rare diseases and is principal investigator for many clinical research trials in paediatric endocrinology and diabetes, and is the coordinating investigator for Soleno's Destiny trial, and that's the DCCR drug that we've heard of this morning. So thank you very much.
Okay. I'm going to talk about healthcare of children and young people with Prader-Willi syndrome in the UK and Ireland. So as I said, we have developed guidelines for the care of children and young people with Prader-Willi syndrome. So as you all know, Prader-Willi syndrome has an incidence of about 1 in 10,000, 1 in 15,000, and is therefore a rare disease. It's due to an abnormality of chromosome 15q. Initially there is hypotonia, poor feeding, faltering growth in small babies, and later on this is followed by weight gain and hyperphagia. But there are also additional features of Prader-Willi syndrome: the hormone deficiencies, undescended testes, delayed development, learning difficulties, respiratory difficulties, behavioral difficulties, skin picking, scoliosis. And therefore we felt that we wanted to develop guidelines that incorporate all these aspects of Prader-Willi syndrome. And we felt that they were needed because there is not one document that describes the best practice for children and teenagers with Prader-Willi syndrome in the UK and Ireland. And we also felt that non-specialist healthcare providers needed guidance of what is the best care for children with Prader-Willi syndrome. And we also wanted to document that potentially can increase equity so that all children with Prader-Willi syndrome develop the same level of care. And we wanted a document that allows clinical services to assess what their service is missing, which gaps there are, which then allows them to work towards filling those gaps. And we wanted a document that provides parents with some information of what they can expect. So we used the standards for development of pediatric guidelines from the Royal College for Pediatrics and Child Health. They use criteria from the appraisal of guidelines for research and evaluation instrument, and that allows you to, that all guidelines are developed in a similar fashion. The scope of the guidance is the management of people with Prader-Willi syndrome that are diagnosed before the age of 18, up to and including transition of adult to adult care, but it doesn't include the care for adults with Prader-Willi syndrome. So this is a picture of the clinics that were involved in development of the guidelines. It were mostly the pediatric endocrinologists initially that came together to develop the guidelines, but then also we included community pediatricians, pediatricians with an interest for in Prader-Willi syndrome, and parents, so Robin was involved, PWSA, so Susan was involved, and also other healthcare professionals, so dietitians, psychologists, and for specific topics we invited respiratory physicians and orthopedic and spinal surgeons. So this is the content of the document. So we'll go through all those different topics and discuss in summary what the guidelines say. So the first one is multidisciplinary team working. So the aspects of Prader-Willi syndrome that need attention by healthcare professionals are growth and hormones, weight, initially genetics, the development and learning, sleep apnea, breathing, behavior, problems with bones, undescended testes, eye problems. So therefore the team needs to involve all the specialties that look after those aspects. So in general, in the center of the organization of the care for children and young people with Prader-Willi syndrome is the pediatric endocrinologist or a pediatrician with interest in Prader-Willi syndrome, ideally supported by an endocrine nurse, which can function as the key worker for families. So families have one single person to contact if they need help. And the pediatric endocrinologist should have access in a multidisciplinary team to a dietitian, to the geneticist, mostly initially, and then later on, maybe when the child is reaching adulthood, respiratory physicians and ear, nose and throat physicians, psychologists or psychiatrists or chems, the child development team that has links to physiotherapy, occupational therapy and speech and language therapy, and then other professionals such as the urologist for testicular surgery, orthopedics or spinal surgeons, and ophthalmologist. Then, of course, outside this team, there's the school, and PWSA, social services. So the team, either as individual members or as a team, will have contact with these other organizations. And contact with schools is really important. Contact with PWSA, of course, is important, but also indeed contact with social services if social services are involved and there are meetings. Then it's very helpful that somebody of the team is present at those meetings. And then how do those specialist clinics interact with other clinics? So we have now more or less set up a network of PWS specialist clinics in England and Scotland and Ireland, and we can interact with each other quite easily now. Interaction with non-specialist teams can be through hub and spoke model, and that is something that we intend to do. So starting at the beginning with genetics for Prader-Willi syndrome. So when children have severely low muscle tone or hypotonia and difficulty to drink, failure to thrive, maybe have undescended testes, then that's an indication to do genetics for Prader-Willi syndrome. So nowadays, most children are picked up in that neonatal time as a young baby. The genetic test that is used, it's called a DNA methylation test, is a relatively easy test where Prader-Willi syndrome can be diagnosed quite easily. So what's found on the test is that there is a lack of expression of the genes in the Prader-Willi syndrome region on chromosome 15. Then after this initial testing, further genetic testing is required, where often the blood samples of parents are needed to determine what the exact underlying genetic mechanism is. And the two most common mechanisms are either a deletion of the region on chromosome 15 that's inherited from the father, so that's called a paternal deletion, or maternal uniparental disomy, which means that two chromosome 15 regions are inherited from the mom and no chromosome 15 region is inherited from the dad. And then there are some rare other causes of Prader-Willi syndrome. So we refer to the pediatric endocrinology team, like as soon as possible after the diagnosis, because we can support and give information, and there are also already some investigations that need to be done in that initial neonatal time. So here on the top right you can see the different genetic mechanisms for Prader-Willi syndrome. So on the left you can see in blue a chromosome from a healthy father, and on the right a chromosome of a healthy mother. In Prader-Willi syndrome here In this part of the slide, you can see that there is a paternal deletion and those chromosomes on chromosome 15 are missing. In maternal uniparental disomy, there are 2 chromosomes inherited from the mom, and therefore you don't have that part of the paternal chromosome 15. And then in other rare forms of Prader-Willi syndrome, you may have a chromosome from the dad and a chromosome from the mom, but you still miss the paternal part, and there are 2 maternal parts of for chromosome 15. And that again can have different genetic rare reasons. Some of these rare causes are inherited, meaning that if the couple had another child, you may be at a 25% risk of having another child with Prader-Willi syndrome, but that's very rare. Most of the time, there's a very small chance for of having another child with Prader-Willi syndrome. So at the diagnosis, it's important to take a good history from the pregnancy and the first days, potentially weeks of life, do an examination, discuss the result of the genetic testing, and refer to a geneticist to understand the exact underlying mechanism for the Prader-Willi syndrome. Discuss features of Prader-Willi syndrome and current insight for long-term management, although at that time still focus on the next few weeks, months, and not focus on the next 18 years, but mention it. And of course at that time already refer and mention Prader-Willi Society patient associations, PWSA UK or PWSA in Ireland. Most of the time children at that time have a nasogastric tube for feeding. Usually that's only needed for maximum of 6 to 12 months and often shorter than 6 months. We now aim for babies to reach the lower centiles of the chart and not necessarily gain weight to average weight of a child of their age. Want to avoid overfeeding, and it's acceptable if they grow on a lower centile than their actual height. Before they can completely move to normal feeding, it needs to be assessed whether they have a safe swallow, because sometimes due to the low muscle tone, it may be that the swallow isn't safe and that food then will end up in the lungs rather than the stomach. So it's important to test that, and it's usually being done by speech and language therapists still at that early phase in their life. It's also important at that stage already to assess for respiratory problems, because sometimes due to the low muscle tone, the chest doesn't expand sufficiently and the lungs are unable to take up sufficient amounts of oxygen. Sometimes there can be something called central apnea, which means that the brain and the hypothalamus doesn't quite give the signal to the baby to breathe, and therefore the baby may breathe less frequently or have long pauses, and again that may lead to lower oxygen levels. And especially at that early stage in life that can happen already. Hormone deficiencies can already be present at that time, and especially thyroid hormone is something to test for, because it's important to replace if that is low. Boys are often born with undescended testes, and then we can discuss with parents that requires surgery, but usually there's no major urgency, and we would even leave it until later than other children with undescended testes, because the surgery often is a little bit more difficult compared to other to patients that do not have Prader-Willi syndrome and have undescended testes. And of course, at this time, all healthcare professionals need to appreciate the parents' concerns and the stress, but at the same time allow for bonding with the child, which is really important. So monitoring growth and weight. So height and weight should be measured at every clinical visit, so already when they're in the neonatal unit, but then afterwards every time when they have a visit. The height and weight needs to be plotted on standard growth charts for children and young people, and not on charts for Prader-Willi syndrome. Because the charts for Prader-Willi syndrome are now very outdated, when management was very different. So we don't really want to compare the children of today to children that we have heights and weights for 10, 20 or 30 years ago. So we want to compare them to children without Prader-Willi syndrome. So the body mass index, so that's the weight for height, should be calculated and plotted, but at the same time healthcare professionals need to keep in mind that the BMI is a poor reflection of body composition because children with Prader-Willi syndrome have lower muscle mass. So BMI of, for example, 15 in a child with Prader-Willi syndrome compared to a child without Prader-Willi syndrome would indicate a higher amount of fat and a lower amount of muscle in the child with Prader-Willi syndrome. So it is okay for children with Prader-Willi syndrome at that early age to have a relatively low BMI, and we don't necessarily need to be concerned about that. So we aim for a stable weight trajectory along a centile that's in proportion with the height. So it can be on the same centile of the height, on a lower centile of the height, or a higher centile of the height, but ideally they follow the centile. And lower centiles can be accepted for weight as long as height is not affected. So nutritional requirements. So children with Prader-Willi syndrome have the same macronutrient requirement as other children, but they have lower energy requirement. Already from before the age of 2, their energy requirement reduces, and therefore with the same amount of calories, without being extremely hungry, children with Prader-Willi syndrome may gain more weight. So their energy requirement is about 60 to 80% of children without Prader-Willi syndrome. And then the hyperphagia often starts between the ages of 4 and 8. On the right is a picture of the need to know nutrition for children with Prader-Willi syndrome from the PWSA. It's a very informative guide to read. So it also means that children with Prader-Willi syndrome need to get fewer calories, but at the same time still need to get the same macronutrients. So they need to have a very high quality diet, and it is helpful to measure the zinc, calcium, vitamin D levels in the blood occasionally to assess whether they fulfill their macronutrient requirements. So there are different strategies for their diet, and different families and different clinics will prefer different strategies. Prevention of obesity is easier than reversal of obesity. That's the same for children with Prader-Willi syndrome compared to children with obesity for other reasons. Reversal of obesity is harder than prevention. So focusing on prevention is what we aim for in the guideline. There is no evidence for specific diets. The energy restriction needs to go together with an increase in energy expenditure. So indeed exercise and movement is extremely important. There are different ways to get the dietary to reduce the energy intake by either portion control or calorie counting or point diets. There are different ways of doing it. It's important that there's a consistent approach from everybody that's involved in the care of the child with Prader-Willi syndrome, including other family members, school. A secure food environment is more and more promoted, both physical and psychological. So physical, that there is no unhealthy food or food that the child shouldn't have around the child, but psychologically that the child knows when there is going to be food available again, and to stick to routines and stick to expectations of the child. Exercise is essential, and there's an advice against bariatric surgery, because bariatric surgery does not treat the hyperphagia, and therefore can lead to severe complications, including stomach rupture. Growth hormone. So growth hormone treatment is available for every child and young person with growth hormone with Prader-Willi syndrome. So about 40 to 100% of children with Prader-Willi syndrome have a lack of growth hormone production, but there's no need to test that before you start with growth hormone treatment. Sometimes clinicians find it still helpful to test if they think that a child is severely growth hormone deficient, and that can be done, but it's not absolutely required. So growth hormone treatment is mostly given for the effect on muscle and fat, so reduction of fat mass and increase in muscle mass. It will also improve height, but that's not the primary aim. There is evidence that there is effect of growth hormone treatment on development at early age, and there's no evidence that early growth hormone treatment increases sleep apnea in young children. And there is accumulating evidence that early start of growth hormone treatment improves the outcomes for body composition. And can see that in the graph on the right, where a group of children that were started below the age of 1 in black, not in blue, that's a mistake on the slide, in black are compared to children that were started between the age of 3 and 8. And especially the very steep reduction in fat mass in that first year of treatment is clear in children that are started very young. So we now recommend that growth hormone treatment is started at the latest by the age of 1, but it can be started at 6 months, or sometimes clinics even start earlier. For all the children, there are some reasons not to give growth hormone, but they're not common. So uncontrolled sleep apnea, uncontrolled type 2 diabetes, and uncontrolled hypertension. But once those things are under control, then start of growth hormone treatment is fine. So growth hormone treatment can lead to obstructive sleep apnea. So that's a type of sleep apnea where the air entry is obstructed usually due to floppy breathing tube, or to increase in size of the tonsils and the adenoids. And growth hormone treatment can lead to increase in size of the tonsils and adenoids. And that's why it's important to do a sleep study before and after the start of growth hormone treatment. It should be a high intensity sleep study called a level 2 cardiorespiratory sleep study, where you measure oxygen, but also the heart rate, the respiratory rate, and you actually video the child so you can see the quality of sleep. It's useful to be able to involve the pediatric respiratory team to assess the results of the sleep study, because they can be very difficult to interpret. So infants with Prader-Willi syndrome can have central apnea, and therefore a sleep study soon after the diagnosis is useful. Central apnea will need treatment. Sometimes it's just with some oxygen, which is relatively easy to give, but and sometimes with other interventions, but it doesn't need to delay growth hormone treatment, and growth hormone treatment can even sometimes help the central sleep apnea because it increases the muscle tone. A moderate or severe obstructive sleep apnea does require intervention and treatment before growth hormone can start. So then you have to start treatment for the sleep apnea, repeat the sleep test 2 or 3 months later, and then reassess whether growth hormone can be started. After the start of growth hormone treatment, the sleep study should be repeated 2 or 3 months later, and then again every 2 or 3 years if there are no symptoms, or more often if there are symptoms of sleep apnea, up till the age of 5. So what to do when growth has finished? So there's increasing evidence that there may be an advantageous effect of growth hormone treatment in adults with Prader-Willi syndrome, but it's still quite ad hoc studies and not sufficient data for it to be an official indication for growth hormone treatment. So Prader-Willi syndrome in adults is not an official indication for growth hormone treatment. However, growth hormone deficiency, so that's insufficient production of growth hormone, is an official indication. And then young people can continue growth hormone treatment at least until the age of 25. So therefore it's important to test the growth hormone production in adults with Prader-Willi syndrome. And our advice is that that happens in the adult endocrine services, because specific tests need to be done that take into consideration the weight and potential obesity of the patient. And there are different tests than those that we do in pediatric care. The growth hormone needs to be stopped a month before retesting, and therefore our recommendation is that after growth has finished, which is often 15, 16, 17 years of age, before transition an adult dose of growth hormone is started. That's a lower dose of growth hormone, and children and young people are then kept on that dose until they transition to adults. And then in the adult team, they can be retested for growth hormone deficiency. There are the same contraindications for treatment in adults as compared to children. So what about puberty and testes? So like I mentioned before, the majority of boys with Prader-Willi syndrome have undescended testes at birth, and the majority of those will require surgery. Sometimes testes will come down to the ball sack spontaneously, but most of the time they don't. Surgery is quite hard because the testes are often quite small, the anatomy is slightly different. So many urologists want the babies to be a little bit bigger before they do surgery. So most for children without Prader-Willi syndrome, the guidance says that it should be done before the age of 1, but in children with Prader-Willi syndrome, we feel that that's not appropriate and that can be done at a later stage. And the urologists and surgeons are usually the best people to determine when there is the right time. And families need already need to get the information that surgery is more difficult, and about 20% of patients with Prader-Willi syndrome require resurgery, and that is much more frequent than in children without Prader-Willi syndrome. Early pubic hair development is common in boys and girls with Prader-Willi syndrome, and that's not usually a concern. It doesn't usually indicate severely dysregulation of hormones and does not usually require treatment. Puberty often starts spontaneously but then fails to progress, and blood tests will then indicate when testosterone levels are too low and when treatment needs to be started. Treatment is important because it's important for quality of life, it's important for muscle strength, and also important for bone health. And we advise for testosterone gel rather than injections because it gives a more consistent level of testosterone in the blood, and to increase the dose slowly. So usually that will be every 6 months. And there's a national guideline for the treatment of delayed puberty, and that guideline can also be followed for children with Prader-Willi syndrome. It usually doesn't affect behavior, but at the same time, if there is a specific event coming up that's of great importance for the family or the boy, then you may consider delaying testosterone treatment. But you can't delay it for too long because of the effect on muscle strength and bone health. For adults, long-acting testosterone injections are available, which are not suitable in children. And fertility in males has not been reported. So in girls, estrogen treatment is needed if there's no pubertal progression. So we recommend estrogen patches, again, because they give a more stable level of estrogen in the blood, and again, there are national guidelines that can be followed. After the first period, either patches can be continued or gel, and they then need to have, rather than only estrogen, also progesterone. And pregnancy in females is possible and has been reported also in the last few years. Females with Prader-Willi syndrome have a 50% chance to get a child with another syndrome called Engelmann syndrome because of the genetic cause of Prader-Willi syndrome and Engelmann syndrome. People and families need to keep in mind that estrogen treatment or hormone replacement treatment is not anticonceptive. So it's important to discuss and think about sexual activity, of course also consent, vulnerability, and also anticonception. Transition is usually a good time to discuss this, and the PWSA has very good information on their website. So other hormones, hypothalamus and stomach. Other hormones, the adrenals are glands near the kidney. They produce a very important hormone called cortisol. There was concern over the last 5-10 years really that many children with Prader-Willi syndrome had insufficient cortisol production. That hasn't really been proven to be the case, and therefore we do advise against regular screening because screening is difficult and will often then require further testing, and then difficulties about whether you should start treatment. So we advise to only test if there are clinical signs of adrenal insufficiency, which is rare. It's important to check the thyroid at least once a year, and it's important to test for type 2 diabetes in all the children, especially when they're going through puberty. We haven't got quite time to go into treatment of type 2 diabetes in children with Prader-Willi syndrome. There is some advice in it in the guideline, and I'm very happy to talk about it afterwards. Hypothalamus, so we know children with Prader-Willi syndrome have different temperature regulation, do not get fever as easily as other children, and have dysregulated thirst. So that's something to keep in mind when children are ill, and also during hot summers or during exercise. Stomach and bowels, there's reduced gastric emptying, reduced bowel movement and constipation, and Anne will touch on that in her part of the presentation. And there's a risk of stomach rupture, very rare in children, but not unheard of in adults and young adults. So acute illness, accidents, and surgery. So children with Prader-Willi syndrome have normal immune function, and they can present less ill than they actually are due to their lower pain threshold, their reduced ability to vomit, and their reduced ability to produce a fever. So therefore there should be a low threshold for further investigations when children with Prader-Willi syndrome present with an illness. When they're admitted to hospital, it's really important that healthcare professionals look after them, support them in their behavior, reduce the anxiety by knowing what their usual routines are, by allowing parents to be involved in the care. Be also aware of their hyperphagia, ensure that as much as possible there's a safe food environment around them in the hospital ward. And anesthetists also need to be aware of their different body composition, their sleep apnea, because that has consequences of for the anesthesia. So lastly, hips, scoliosis, and bones. So hip dysplasia is a little bit more common in babies with Prader-Willi syndrome, still only in very small number, but all babies with Prader-Willi syndrome should be examined, so to have a screening examination, and if there are concerns, should get an ultrasound of their hips. Scoliosis is so a curve in the spine is quite common in Prader-Willi syndrome, but can be quite mild, and if looked after from an early stage, may not progress as quickly. Strengthening of the core muscles is really important. There's no evidence that growth hormone worsens scoliosis. Yearly examination is important. Scoliosis occurs more often when there's rapid growth, and therefore during the first 5 years of life we screen with X-rays, and then again during puberty we screen with X-rays, and in between only if there are concerns on clinical examination. Bone density can be reduced due to low growth hormone, and especially low estrogen and testosterone, but there's no reason to assess for bone density before that time of puberty. But before children and young people are transitioned to the adult team, it is a good time to assess the bone density. And it's always important to optimize bone health with exercise and ensuring appropriate levels of vitamin D, as many people with have low levels of vitamin D. It's important for bone development. So now I'm going to hand over to Anne.
Let's go back that one, which is the going back. That one. That one.
That one.
It's
Yeah.
just, thanks very much, Evelyn. Can you hear me? So just incidentally, we noticed this was an image that Evelyn found to illustrate scoliosis, but looking closely at it, we also see this child is extremely loaded. Their bowel is full. So it's a kind of to me, it illustrates how silent constipation can be in children, and it is something we find in children with other developmental conditions. Constipation creeps up on you, and that's what I'm just going to touch on that very briefly. Let me get this the right way around. So, just picking up where we've got to. So the muscles internally and externally are affected, are problematic in Prader-Willi syndrome. Let me get my reminders in case I miss some points. So it's not clear. The causes of hypotonia, low tone, muscle weakness, and movement problems, motor delay, in PWS are not clear, but there's definitely a reduced muscle mass. So there's just always a lower amount of muscle, which is, the figures vary, 25 to 35% possibly. And there are probably slight abnormalities in the way the muscles work. And for me, muscle is an exercise is a very important part of the whole management of Prader-Willi syndrome. It's something to build into life, go up the stairs, walk, get off the bus early, walk rather than getting in the car. Maintaining the muscle is really important, because otherwise you can get a spiraling down. The less you use something, the weaker it gets, the less you use something. And having exercise increases well-being, so if you are fitter, you release some of the hormones that give you some sense of well-being. And obviously it's also important for your future bone strength. The exercise you do in childhood it contributes to the density of your bones, and as an adult, and osteoporosis is commoner. Growth hormone does improve it, but you also have to do exercise as well. And then internally, different type of muscle, but there is this tendency to constipation, which is there's a slower movement through the bowels. There's decreased motility or movement in the bowel, and it really does creep up. So the figures, we just don't know what the figures are, how common it is, but if you're loaded, you feel uncomfortable. Sometimes people know, and sometimes they don't. And in my experience in other conditions, sometimes treating the constipation improves the behavior. So Movicol can be a fantastic treatment for challenging behavior, which sounds curious, but reach for the Movicol. So constipation is one part of it, and the other part is the stomach. So stomach emptying tends to be slow, and so the stomach is vulnerable. Children are vulnerable for putting too much food too fast and choking, or more rarely rupture and other difficulties in the stomach. And as we were hearing, bariatric surgery would be definitely contraindicated. And then coming on to more the territory that I specialize in. So as you know, we call Prader-Willi syndrome a neuro-developmental disorder. So it's the developmental learning and behavioral difficulties form a major part of life with Prader-Willi syndrome. And this is just a sort of schematic way of representing how these things overlap. There's the development, which I'll just mention in a sec. There's all the behaviors, and I think most people possibly that went to the very good workshop with Natasha just now, the behaviors, there's a behavioral phenotype, there's cognitive difficulties which range between severe, mild, moderate, and spiky sort of profiles. There's the physical issues of tiredness, of hunger, of illness that is a bit silent, and then there's external events. So all those things come together. So when we look at development, we break it down, and these are the things that this is standard about motor, speech, language, social, cognitive development. And all these things may be affected, and usually are, to varying degrees in children with Prader-Willi syndrome. So you have the gross motor, we call it the large movements, which is the muscle, low tone, relative weakness, delay in muscle related or movement, gross motor skills, with a lot of catch-up, and with no clear link between, it's not an indicator in general terms, it's not an indicator in itself of intellectual, or of other abilities. It's a particular thing, it's about the muscle. And then you may get fine motor difficulties, which are fine movements of coordination. Speech and language, so may have a general delay, which delay means you're probably going to catch up, or you may have a disorder, which means that it may last much longer, or some children that it continues to be a very long-lasting disorder of language. And then you have specific difficulties within language, which may be to do with processing information, finding words, and you may have a formation of words difficulty, or a regulation of that. So there's different aspects of speech and language, and speech and language is so fundamental, because communication is so basic that if you can't communicate, it's very frustrating. It's very easy to see how communication, either receptive, understanding, so language is more about receiving information, understanding verbal information, processing it, and having enough time to do that. Not being able to communicate what you want is really important. Hence, we need to really be clear we identify what those difficulties are and put interventions in place. And that applies to everything. The whole message from child development and my territory is to understand, to unpick, to understand and work out what's wrong, what the difficulties are, what works and what doesn't, and try to keep pulling all that together. And then social issues, that there are difficulties with social communication, social understanding, picking up cues, processing the everyday things of empathy and play and relationships, which become more prominent as children become adolescents in terms of their impact quite often. And then there's cognitive. So children, we keep hearing about that. So there's a shift to mild to moderate learning disabilities, and then some children have more severe difficulties, and then some people have specific difficulties such as processing of language or these other things which overlap with behaviour, which are neurologically based. So the behaviours, again, I've just put them all together because I'm not going to go into everything in detail because there's been a very good workshop earlier on, but these behaviours are part of this whole pattern, and they form what's called a phenotype. It's a description, very typical. And children tend to have these difficulties to an extent. Children with Prader-Willi syndrome have these difficulties to an extent, but obviously to varying degrees, and they will interact as well. So the meltdowns it's not an intrinsic meltdown. The meltdowns they're a behaviour which come as a result of a number of factors usually. Inflexibility is more of an innate tendency, the rigidity. The issues of task switching, which I don't know if you've heard about that, which have been shown on scans. Our colleagues from Cerebra have done some good work on that, showing that in Prader-Willi syndrome, different parts of the brain light up when we stop doing one thing and start the next thing or change that. In Prader-Willi syndrome, there's various particular patterns. So people needing to know that the child needs time to stop doing that, needs warning, and then before they start the next thing. That will affect transitions, as will other factors. Then there's the whole category of repetition, getting stuck on a topic. Perseveration means can be getting stuck on the topic, getting stuck on the task, having to keep on doing something, and obsessing about something or a thing someone said or their own interest. Anxiety is a characteristic which may come as a result of other things. It may be something that's a consequence of the world's a complicated place. When we hear about children tiring, there are multiple reasons why children tire as the day goes on. Some of that is physical tiring. Some of it is because there's so much to do, so much to process, that it's very tiring as well. And anxiety may come with that, but it isn't clear what the anxiety, but it's a common feature. I mentioned social understanding. We've touched on skin picking, I think, in the behaviour workshop, but skin picking is a very particular characteristic in Prader-Willi syndrome and a few other genetic conditions. So it's not fully understood, and there are interventions around that. It possibly is more common, more likely to happen when somebody's bored or they're tired, but there are other reasons as well. And obviously we know about hyperphagia. So I think that the sense that all these behaviours are there for different reasons and interact, I think, is what we're trying to say. So the consequences of all these are that children's educational needs need to take into account all those factors. So that there's the intellectual band that the child is in, and there's the general intellectual band, and then there's the specifics under it. And then the educational setting needs to be able to take account of all those other factors. And in my experience, we should, well, in life, isn't it really, make no assumptions. So sometimes we'll get involved in a situation in school, and again, I think I was listening to somebody's story earlier on, where people think things are in place, but they're not. So the educational settings need to be encouraged to take advice, and that the materials and guidance that the PWSA produces are great, and we routinely would direct them to that. We often find they've already seen them, the films, the materials there. That's really important. But then there's a matter of double checking on that, and you sometimes come across, oh, I know what's best. This one just needs that. This is this. That I've been a Senko for, nothing wrong with Senkos. They are great, but I've heard somebody's, wears bad. I'm not saying it's teachers, but it's people can not understand the complexity of the PWS and generalize about what is required. So the detail of all these things is required in the educational needs. Children nearly always, if not always, need support in school. I think they all probably do, of some sort, which is that advocacy or that checking or that light touch. It's more difficult when they're more able and they're in a mainstream school. Sometimes as they get older, that needs to lessen. They need, and the educational healthcare plan needs to be reviewed and kept up to date. It's not just a one-off. It's something that needs to be, what's going on and does everybody understand? And when it comes to behaviour advice, all those factors that I've mentioned in terms of development and learning and behavioural characteristics, again, need to be taken into account. So we need to share the skills and share the knowledge and use the sources of advice that we have and seek help when we can. And the reality is that it can be difficult to find the expertise that is required. And that's one of the things that people like us will continue to measure, advocate for, campaign for, the sort of advice that people say that they need. But there is behavioural advice. Psychologists can be particularly helpful. CAMS can be helpful, but we know that unless you see somebody who understands PWS and this complexity, these whole picture, it can be disheartening. It can be not very helpful. And there are more specialist services such as which have to go through CAMS, such as at the Maudsley. And family and carers are again, all these things are topics within the guidance, where we've just picked out the headlines really, because there's so much to say under these, just the key things. And the importance of support and providing recognition for the burden and that's a word that's come out of the literature, but the impact on parents and families is recognised as considerable, and the support and understanding around that and what can be done to help is really important. So in our clinic, our Prader-Willi syndrome clinic, we have found it so helpful throughout all the years to have a parent advisor in the clinic from the PWSA, which has been a really, really important aspect of linking into other services. Mental health, there is a higher rate of mental health disorder in late adolescence and adulthood. The data on it, or the figures on it, or the rates, it's really difficult to know because you've got old data, old figures. We don't know. We work in a much more prospective way now. There's much more of this understanding and support going in for young people. So we don't really know, but there's anxiety and depression are commoner, and psychosis is commoner, particularly in the maternal disomy, but also can occur in both of the main variants. But the figures around that are not clear, and the important thing is that to be aware that can be there, and if there's changes in behaviour or there's other difficulties, to be aware that there may be something going on, and to get the assessment done by a psychiatrist, again, who takes advice or has expertise in PWS. So, short thing on transition. So transition meaning from paediatrics into adult care. We talk about starting transition relatively young. That's traditional in the learning disability world, just thinking ahead. When we are getting to the point of transition, we nowadays would always refer the child onto, or the young person, onto an adult endocrinologist. Until, relatively recently probably, quite a lot of adults were not on estrogen and testosterone replacement. Their bone health and their cardiovascular, their weight has not been kept under review by a specialist. So we would absolutely clearly make sure that children are referred on. And in our service, we have identified an endocrinologist who's interested in, an adult endocrinologist who's interested in PWS, so he meets with us and we do a joint handover, and then he can also, we're there if needed, because we might know more about certain aspects of PWS than he feels he does, but he's jolly good. Dietitian is another part. Access to a dietitian is an important part going forward, and we try to do a health summary so that it's there. It's a document which the young person can have and keep, which talks about, it's all in one place, don't have to repeat everything, it's there. It's summarising key events, key issues, and it's there for people to refer to. Part of transition is thinking about where someone's going to live, what sort of continuing education they're going to have, what sort of employment, and we know of lovely stories, and some of the young people, because I've been doing it probably more than, I think 16 years must have been last time I stood up here or stood over there, so I've been going, so some of the young people, I think the oldest I know, I've known her since infancy, is 23 or something like that. So what you see is young people going into employment, and it's great. It's supervised employment, sheltered employment, but certainly employment, and that's great. And we need to think about funding and what sort of allowances, and all that needs to be pulled together. Touch on mental capacity, because I'm nearly at the end. Mental capacity is a tricky topic, and there are 4 key criteria, 4 sort of underlying principles within it. And I think it's really important that mental capacity is addressed for an adult, or once you get beyond 16, with PWS, because the key issue is, does that person have the capacity to make safe, life non-threatening decisions about food? And that's the main territory. And that's something that, so I had a discussion with I was asked to, someone who used to be under our care, who's about 20 now, and social worker, and I met with one of our colleagues here from PWSA the other day, and it seemed a really enlightening conversation. Don't you think? She was very appreciative, wasn't she, of the social worker understanding the complexity of the food aspect of Prader-Willi. It doesn't go away. And so having someone to explain that and to look at that and think about that is important, because what I also know is that there are places who provide care for adults, young adults with PWS, who have not understood that. Who think, oh, well, on Friday night we'll all go down the pub and have crisps and this, that and the other. And it throws, and it's confusing, it's muddled, it's the same principles apply. It's more relaxing, it's less anxiety making, I think, we're told, young people tell us, children tell us, if that is predictable and those things are taken, those possibilities are taken away, if there's a consistency about that. And once you get into a cycle of breaking that, it's harder to unpick. Social care has a role. Learning disabilities team are multidisciplinary teams, but the intellectual levels that they deal with sometimes mean that they're not available. They have sometimes they have a cut-off that's more severe. But learning disability teams, if we can access them, are very good because they're multidisciplinary adult teams. So in summary, try to leave you a few minutes to ask questions. The reasons we did this, because we felt we needed to update, look at the literature, talk to each other, and pull information together so it could be a reference point. And what we knew already, there's multiple health elements to Prader-Willi syndrome, and that a lot of people have written about multidisciplinary care is required, so lots of people required, and this needs to be joined up. And that's the next challenge, really, how that's best done. But this is a guide towards that, and some areas are more multidisciplinary than others. The rarity of the condition means that the child's needs may be unfamiliar, so we're trying to nudge and point people, professionals who know less about this, to look at the documents, look for advice. There is this. The guidance it's a big academic-y document for publication, because that's what it needs to be. It needs to be accessible on the internet, accepted pucker needs to be out there as a peer-reviewed publication. And from that, we've almost finished, but we're waiting till we've got this sort of final publication really before we put a summary into the PWSA website. But the document will be there for anybody to read, and then the kind of the key elements, because you really want a working document from this. I've done it as sort of, it's almost 2 sides really, that's it. Highlighting the sort of the key things from that. And that's, we want, to be readily available and pragmatic, practical. We suggest this hub and spoke idea so that you have a few specialist clinics who can work with local folk, local professionals, and communicate jointly. And but we've all, we can ask Evelien how her clinic arose, but we just appeared. We're like mushrooms or something like that. We just appeared. We decided just to get together. We're not, I don't think any of the clinics have been commissioned by anyone. I don't think they've been set up by anybody high up. We all just got together and just sort of, well, this is much better if we do it together. And what we'd like to see is, it's not that difficult to do that, to be honest, but but you've got to stick at it. And the advantage of having a specialist clinic is that we've gained so much by meeting so many children and parents, and it's a mutual learning really. So we can give back. We also take from what we experience with you. So it's to have specialists makes sense, but also to link with more local services is what we do. So children come to us from really that side of Wales, Lincolnshire, other places, Essex, all over the place. They come to our South Coast hub. But there are more clinics now than there were in those days. And the advantage of having specialist clinics is that we can do this kind of thing. We can share information, we can check things out, we can facilitate research, and we found there's quite a few gaps and things that do need to be done, and we can develop the guidelines. So any questions, and I'm sorry those are the people involved. This will probably be accessible, this presentation, but it's acknowledging and showing you perhaps why it took us a long time. A lot of people were involved, and there's a lot of material and information and double checking. So any questions?